Hi everybody, my name is Sarah Master. During the year I attend Brown University, but this summer I had the pleasure of working in Dr. Wyrick's lab at Hunter College, studying trauma-related symptoms and reduced gray matter volume in the ventral anterior cingulate cortex. So first, let's talk about what classifies as trauma exposure. A traumatic event classifies as such if you experience the appropriate levels of fear, helplessness, or horror in reaction to experiencing, witnessing, or learning about an actual or threatened death or serious injury or other threat to one's physical integrity. So this just means that it can happen to you, it can happen to someone you know and you can hear about it, or it can happen to someone you don't know and you can watch it happen. And those things all classify as a traumatic event as long as you experience, again, that fear, helplessness, or horror, and a physiological activation in response. Immediately following a traumatic event, one may experience trauma-related symptoms, which the DSM-IV, or the Diagnostic and Statistical Manual of Mental Disorders, the 4th edition, breaks into 3 clusters of symptoms, which are re-experiencing, avoidance, and hyperarousal. Re-experiencing is a cluster that encompasses reliving your trauma in various ways, maybe nightmares, intrusive memories, or flashbacks. Avoidance as a cluster encompasses avoiding any sort of reminders of the traumatic event, such as the place where it happened or anybody you might have been with when it happened. And hyperarousal as a cluster encompasses symptoms of overactivation of the body, namely insomnia, bouts of anger, or hypervigilance for potential threat, a paranoia of sorts, sort of watching out for things that might be threatening to you. Again, after a trauma, people may experience trauma-related symptoms or they may not. They may be on one end of the spectrum, which is less affected, meaning that they immediately recover from the trauma and move on. Or they might be on the other end of the spectrum, meaning that they're extremely affected, they have many symptoms that persist over a long period of time, and they might even qualify for a diagnosis of post-traumatic stress disorder, or PTSD. One brain area that has been implicated in trauma-exposed people is the anterior cingulate cortex, or the ACC. It's the blue part of this diagram here, and as you can see, it's part of the frontal lobe. It sits right about in the middle of your head, right here, and it is considered a part of a frontal control network. What's interesting about the anterior cingulate cortex is that it is divisible into 2 functionally separate regions. So you have the dorsal ACC highlighted in red and the ventral ACC highlighted in blue. The dorsal ACC is part of the salience network, meaning it's involved in shifting your attention to potentially important or salient stimuli, and it has attentional control over the rest of your brain. The ventral ACC, on the other hand, is more responsible for the control of your limbic affective response, meaning once you detect a potentially threatening or dangerous stimulus, the ventral ACC steps in and says, oh, you don't need to have a large emotional response to this information, it's not threatening, and it sort of dampens your reaction to that information. As mentioned previously, the ACC has been implicated in trauma-exposed people before, and they found almost opposite things in the ventral and the dorsal ACC when they do distinguish the 2 subregions. Functionally, they found less activation in the ventral ACC and more activation in the dorsal ACC in response to negative information in those who have PTSD. And they found less gray matter volume in the whole ACC, meaning their ACC is a little bit smaller in those who have PTSD. But again, that study does not distinguish between the 2 subregions of the ACC. The majority of previous research on trauma exposure has involved male participants, namely because those who have been exposed to combat are often diagnosed with PTSD, and so it's a large population of male participants that are easy to recruit. And they also haven't divided the ACC into subregions. Some studies have, other studies have not. So I was interested in dividing the ventral and the dorsal ACC into 2 separate subregions and investigating the effect that trauma-related symptoms were having on different structural and functional measures. Namely, I hypothesized that the ventral ACC was going to have less gray matter volume and be less active in response to negative information in those who have more trauma-related symptoms, and that the dorsal ACC was going to have more gray matter volume and more activation in response to negative information in people who had more trauma-related symptoms as well. In order to investigate these hypotheses, we had a sample of 21 trauma-exposed women come in for 2 sessions. The age range was 18 to 37, and they were both racially and ethnically diverse as a sample. In the first session, they came in for a structured clinical interview just to assess for psychological disorders, trauma exposure, and trauma-related symptoms. And then they completed a series of self-report questionnaires, namely the perceived stress scale, which assesses psychological stress and how in control of their lives they've been feeling for the past 2 weeks, the state anxiety inventory, which measures how much anxiety they're feeling right there in that moment, and the Beck Depression Inventory, which measures depressed mood over the past 2 weeks as well. For the second session, they came in, and we put them in the MRI scanner, and we obtained a structural MRI scan to see what their brains looked like, and a functional MRI scan to see what their brains were doing, how they were active in response to our task. The task itself was an affective scene viewing paradigm, in which participants viewed positive, neutral, or negative images. These images were presented once, so they were novel, and then they were presented again so that they were familiar to the participants. To analyze the data we obtained from that MRI, we used FreeSurfer FS-Fast, which extracted gray matter volume in millimeters cubed, again, just a measure of how structurally sound the ACC is, and peak functional activation for novel negative information versus fixation, meaning we formed a contrast of those novel negative images that they had viewed and subtracted the baseline brain activation for when they were just staring at a blank screen. We then ran a series of correlations, just looking for relationships between activation in the two subregions, the gray matter volume of the two subregions, and the behavioral measures that we obtained during the first session. In terms of what our population looks like in trauma-related symptoms and the questionnaire measures, they're about exactly where you would expect a trauma-exposed population to be. In terms of their perceived stress, it was just about where it's supposed to be for young women college students. So it was about average there, and the number of trauma-related symptoms, again, was average in terms of those who had been exposed to trauma. As a comparison, they were about right in the middle. State anxiety was actually higher than you would expect in a trauma-exposed population, but not by very much, and the same goes for depressed mood. This just means that they're higher than people who haven't seen trauma in all of these measures, and lower than people who have full-blown PTSD on all of these measures as well. What's also important to note about the behavioral data we obtained is that there's a lot of variance within our population, and this is very important when you're trying to run correlations, which we were. So that was good. So when we ran the correlations, we saw that there was a relationship between trauma-related symptoms and gray matter volume in the ventral ACC, in that the more trauma-related symptoms the participant exhibited, the less ventral ACC gray matter volume they had. There was no relation between any functional activation of the vACC in any of our measures, or the ventral ACC in any of our measures, and there was no relation between the gray matter volume in the ventral ACC and state anxiety, perceived stress, or depressed mood. But there was a relation between the trauma-related symptoms and the gray matter volume in the ventral ACC. We did not find any structural relations in the dorsal ACC, meaning the gray matter volume in the dACC did not correlate with trauma symptoms, state anxiety, perceived stress, or depressed mood. Likewise, there was almost no significant findings in the dorsal ACC in terms of activation. There was no relation between the activation of the negative images, trauma-related symptoms, state anxiety, or depressed mood. But we did find that there was a positive association between perceived stress and dorsal ACC activation in response to these negative images. So what that means is that the more perceived stress the participants reported that they were under, the more activation they had in their dorsal ACC to those novel negative images. So tying that all back to what we've been talking about, we found that the number of trauma-related symptoms was negatively associated with gray matter volume in the ventral ACC. This may mean that pre-existing individual differences in the structure of the ventral ACC may be contributing to how one processes a traumatic event after it has occurred. It could also be indicative of prolonged stress following the trauma, reducing the gray matter volume in the ventral ACC. We're not sure. We didn't assess whether it was a cause or an effect, so we can't exactly make conclusions in terms of that. We also found that the higher the perceived stress, the more dorsal ACC activation to novel negative information there was in our participants. This could suggest that they have maladaptive vigilance for potential threat, meaning they're sort of hypervigilant, constantly looking for information that could be threatening or negative when they're under psychological stress, or when they're or it could mean that the heightened activation in the dorsal ACC might be creating that heightened stress. Again, we can't assess for cause or effect. In terms of the future directions, I would love to investigate the actual behaviors associated with the ventral ACC that might mediate this relationship between ventral ACC gray matter volume and the trauma-related symptoms, namely the cognitive control strategies implicated with the vACC and fear conditioning, as the ventral ACC has been implicated in fear conditioning in the past. And that's it. Thank you very much.